Hello, dear judges. I am Dr. Jason Ho. I represent Warren Care Circle. Today, our topic is reducing the rate of post-operative patients staying in the recovery room for more than 2 hours. Our team member across seven different departments, including POR, Department of Anesthesia, Orthopedics, Radiology, and etc. Tracking the results of previous activities, our rate of surgical patients staying in the POR over 2 hours was 22.3% at 2017. We lowered it to 8.2% at 2019. However, the Taiwan Clinical Performance Indicator was 2% during the same time, so we're still much higher than the average. So we choose this topic by voting according to the factors showing above here. So the rationale for selection is because for patients staying in the recovery room, longer will increase the anxiety, and the longer the patient stays, the more worries their families become. For staff, the extended patient stays will increase the clinical workloading, and for hospital will increase the cost, and affecting the manipulations of the operation room and impacting the data on clinical performance index. So we choose problem solving activity. So this is our Gantt chart. So to identify the current status, this is the flow chart, how post-operative room works. We receive notification of the surgery completion, then the POR nurse member will start preparing the supplies. Then we accept and set patients. Then we start monitoring the hemodynamics and deal with the post-anesthesia related complications. After the patient is relatively stable, the anesthesiologist will evaluate if the patient can be transferred back to general ward or not. If the answer is yes, the patient will be transferred back to the ward after all the record was completed. Post-operative patients stay in the recovery room before this program is 8.26%, and the average duration of care is 1.5 hours. So we use Pareto chart to analyze the possible cause. And we found three possible causes, which is unstable condition, nursing manipulation, and X-ray procedures. These three factors account for 85.9%. So goal setting, the goal calculated at first was 2.5%. However, as just mentioned before, the Taiwan Clinical Presentation Index was 2%. So we want to challenge attractive quality. So we set our goal at 1.8%. So next step, we start analyze the cause. We draw fishbone diagram by brainstorming, and this is the fishbone diagram of unstable status. This is the fishbone diagram of nursing manipulation, and this is the diagram of X-ray procedures. Then we use the Pareto chart to find out the factors which account for 80%. So we find four possible reasons in the unstable status and three possible factors in nursing manipulation and four in X-ray procedures. The first possible cause in unstable status is poor management of acidemia, and the average time stay in POR is 170.2 minutes, which is longer than the target 120. And we got the second reasons, which is potential cardiovascular problems. Average spent 170 minutes each case. So the third is prolonged monitoring of breathing status, and number four is prolonged post-anesthesia management. They all stayed over 120 minutes, so we recognize these four factors as a root cause. So we move on to nursing manipulations. The duration of overtime stays during peak times is 150 minutes, which is longer than 120. And the person to bed ratio during peak time is 2.3, which is higher than target, which is 2. The time required for management the post-operative pain is 110 minutes, and it doesn't include other procedures. And The number 4 reasons is lack of reminder, and we try to add verbal reminders, and each case can decrease about 6 to 10 minutes. So we recognize these 3 reasons as the root causes. So we move on to X-ray procedures. We draw the value stream mappings to find where is the key point of the delay. So we find out that we will spend 47.5 minutes waiting the emergence radiographer, and we'll spend about 16 minutes waiting for the physicians to reply the image view, and we got 64.3 repeated following X-rays, and the positioning difficulties will spend 11.2 per case to finish a radiograph. So we recognize these 4 reasons as root causes. So we got 11 root causes. Next is the solution formulations. We use the fishbone diagram and the root cause verification method to find the root cause, and then use the 5W1H method to find the countermeasures through brainstorming, foolproof discussions, and finally decide the solution by vote. At the stable status, we find several solutions, and I will explain it separately. The first, with the patient have no invasive arterial line, we'll apply the non-invasive hemodynamic monitoring system. It can provide factors of preload, afterload, and systolic function, which can help clinical physicians make decisions more quickly. And in the patient who had invasive arterial line monitoring, we establish a PPV module. These factors can hint the patient's fluid status and improve the tissue perfusioning. So a standard operating procedure was drafted for post-operative care in the recovery room, including PR scores for vital signs and abnormal treatments. And then we provide breathing retraining rehabilitation in POR, which is designed by Department of Rehabilitation. And we also give windmill rehabilitation to pediatric patients. And with the patient who still have endotracheal tube, we'll use end-tidal carbon dioxide monitoring system to decide when is the proper time to extubate. With the prolonged post-anesthesia management, we conduct monthly in-service education on post-anesthesia care. Also, we divide the nursing care zone to zone A and B, and we will assign the zone leaders to deal with the delegating task and offering assistance. So there are four innovations. So we check the result. The usage of non-invasive hemodynamic monitor rise from 0% to 71.8%, and the re-intubation rate in the recovery room was 0. The completion of in-service education is 100%. So for actions, we will discuss reason for delays on a case-by-case basis each month. We'll keep diagnostic manual of non-invasive hemodynamic monitor on the top of the screen of nursing card for easy reference. And we list these online education as compulsory courses for new staff members. We move on to the nursing manipulation. So we divide our nursing zones to zone A and B, and we will assign the zone leaders, and we adjust manpower for the 9 o'clock to 5 p.m. and night shift according to the daily operation schedule. And we add a 2 p.m. to 10 p.m. shift to assist with night shift manpower. Establish workflow. So for pain management, we provide nerve block as an option for a pre-operative self-pay prevention measure. And the nerve block can relieve the pain for about 8 to 12 hours, so we can shorten the observation time if we don't have to give opioid medication. For lack of reminders, we add a stopwatch to remind the staff that this patient had already stayed in the POR for 1 hour. And we also use the anesthesia management dashboard to display the peak and off-peak numbers of patients awaiting surgery. 3 innovations, and for check the result. The person-to-bed ratio has showed improvement, and the patient who received nerve block has rise from 40.1% to 53.9%. And the average duration of care time has reduced to 1.3 hours per case. So for actions, we established guidelines for staff groupings, night shift leader delegation. We track the percentage of patients receiving post-operative nerve block on a monthly basis. And we also will keep tracking the monthly person-to-bed rate. So we move on to X-ray procedures. For waiting for image review, we will remind the radiological technologist that this indicator was the primary indicator of POR, and we will provide medical record numbers along with the image review notification, just in case we can reduce the delay in answering. For the long waiting time of radiographer, we decide to use the strategy of portable X-ray stagnation during peak hours after discussing with the Department of Radiologists. Our nursing member will provide the reminders to radiologists according to anesthesia management dashboard and POR portable X-ray waiting list, just in case our radiographer can finish as much case as possible in one round. And we'll add POR repeat X-ray statistics to reduce the conditions of repeat following X-rays. For positioning difficulties, at first we use a commercially available swimming rings as a support. However, we found it will cause artifact during photographing. So we designed a beanbags with styrofoam balls to provide stable support during positioning. And there are two innovations. So we check the outcome. So waiting for image review has shortening 12.9 minutes per case, and waiting for radiographer has shortening 32.1 minutes per case, and the positioning time has shortening 4 minutes 40 seconds per case. And we still kept following the monthly repeated X-ray statistics in recovery room. So results verifications. After the program, our percentage of post-operative patients staying over 2 hours has reduced to 1.25 hours, has successfully achieved our goal. And the p-value shows significant differences, and the total case was 31,756. The target achievement rate is 108.5%, and this is the parietal chart with before and after the total chart. This is the before and after parietal chart of unstable status, and this is nursing manipulations, and this is X-ray procedures. We can see the components have changed. So the total improvement of unstable status is 84%, and the improvement of nursing manipulations is 95.4%, and the improvement of X-ray procedures is 95.6%. And we did not increase the risk. The patient needs re-entering the operating room from the POR reduced from 5 to 2 per year. So we save about 1.8 million per year. The radar chart scores all showed improvement. So there are still resolving outstanding issues. The first is the low temperature, which is commonly seen in the post-operative room. So we educate our members to detect early and recover early, and it all showed improvement. Another common seen problems is post-operative nausea and vomiting, and we provide a 内关穴 wristband to treat the post-operative nausea and vomiting along with the medication. So for effect maintenance, our indicators still maintain within the target even after the program ends, and it lowers to 0.8% until 2021 October, and the total case number was 42,920. And we can see that the indicator stays within the target through time. And our indicators not only superior to Taiwan Clinical Performance Index, but also better than Australian Council on Healthcare Standards. So for standardizations, we list the process guidelines and monitoring indicators. And for the next issues, we choose lowering recovery room re-intubation rate. For summaries, We has attend several competitions and win several awards. And we by 7 department work across teams, 9 national initiative countermeasures and benchmark innovations. We improve the patient safety, and we also create 6 additional benefits, and we save about $1.8 million per year for the hospital. And thanks for watching.